Good evening, and welcome to the Chicago Chapter National Black Nurses Association Health is Wealth program. We're just so happy to be with you again today. And we have with us in studio the Vice President of the Chicago Chapter National Black Nurses Association, Miss Ethel Walter. And she will be talking extensively a little bit later on. But I also would like to mention that we're just so proud to have our host here with us today, who is none other than Miss Bernetta Pearson. Bernetta has been doing this program for years, and she took a little leave of absence, and we've been kind of filling in for her, but she is sitting out just showing moral support to us today, and we're just so grateful for that. And as always, we always happy to have our telephone technician, Miss Janice Henry, and she's here with Miss Bernetta sitting out today, giving us that support. Hello, guys, and thank you so much for your support, okay? We just want to say that we, from the Chicago Chapter National Black Nurses Association, have been around for coming up 44 years. We will celebrate our 40th year anniversary this November the 4th. And we're going to be doing some exciting things, and we'll talk about that a little later on. I just want to kind of bring Miss Ethel Walter in, our Vice President. And I would be remiss if I did not mention that our President is none other than Miss Ellen Durant, okay? And she's not here with us today, but we know that she's given us her moral support also. So, Miss Walton, we say welcome and hello to you, and thank you so much for pointing us and helping to point black nurses in the right direction. Can you just tell us a little bit about you and what you bring to what you're going to be talking about today as it relates to health care? Because we know health is wealth. And we're looking for our avenues where we can let the people know, and you can call in and ask questions, where health comes to the forefront, and we're going to be the vehicle that gives that to you. So, Miss Walton, would you introduce yourself and just tell us a little something about you, okay?
Well, my name is Ethel L. Walton. I am a registered nurse. I have been a nurse for over 40 years, and I work at Mercy Hospital in Chicago, 2525 South Michigan. I've actually worked there twice. This is my second time around at the hospital, and this time I've been there for 5 years, and I work in the Department of Case Management under the premise of utilization review. Our topic today is not going to be on traditional nursing care. We're going to talk about case management, how that helps the patients, and what the patients can benefit from that the case managers do. Sort of what their job description is, what I do, and how that helps to benefit the patients when they're getting ready to be discharged, so that they have everything that they need and that there's a smooth transition from going from the hospital back to home, or if they need another facility prior to going home, those types of things.
Okay. And Miss Walton, can you just share with us what because a lot of people don't know. They may know what was it QA or that type of thing, but what is case management by definition?
So there are so many definitions of case management, and if you look it up or Google it, you even have a lot of definitions. So I actually wrote a definition down, and then I will try to explain what that means in layman's terms, exactly what it is that a case manager does for a patient.
Okay.
So the definition that I wrote down is that case management is a collaborative process of assessment, planning, facilitation, care coordination, evaluation, and advocacy for options and services to meet an individual's and family comprehensive health needs through communication and available resources to promote quality and cost-effective outcomes. What that really means is that a case manager is going to be the her function is going to be in illness management so that we can try to prevent relapse of the patient.
Okay.
You're going to be an advocate for the patient. You're going to work on discharge planning so that the patient can get the things that they need to successfully succeed at home. And you also want to make sure that the consumer has choices. Sometimes the choices are limited, but they always have choices, and their choices should be listened to.
Okay.
And if they have one that they prefer, we would surely, if it is within our realm, give them their preferences.
Got you. And when does this process take place, Ms. Walton? As a client in the facility, when would you start advocating for me as a case manager? When does that process begin?
So the case managers that are looking at this or that are listening, they know that discharge planning starts the day of admission. Mm-hmm. And that might sound funny to some of the patients when we come in and they're like, I'm going home today. I just got here yesterday. No, you're not going home today. However, we have to start planning on when you go home, mm-hmm. so that when the doctors have completed what they're doing, we have our plan ready and we're not delaying anything. They do not allow us to keep people in the hospital for very long.
Okay, Ms. Walton, I see we have a caller on. Okay. Caller, go ahead.
Yes, good evening.
Good evening.
Great show as always. But I was thinking, why, in a perfect world, the young lady in the pink has the perfect scenario for a perfect world. But it's not perfect. It's only getting worse. And I want to know this. How, if the person relapses, how many times do they have to relapse before you go on to another patient? Thank you.
I'm not so sure that we understood exactly what you're saying, but I heard relapsing. So does that mean that the person had to be readmitted once they was discharged? So can you be a little bit clearer on that, and then we can see if we can come up with an answer. Did we lose him? Okay. All right. I think Ms. Walton...
I can attempt to answer that.
Attempt to answer, right.
Because it sounded like he was asking, do we just forget about the patient if they keep relapsing and coming into the hospital? Mm-hmm. No, we do not. In fact, the very essence of our job is we don't want the patient to come back to the hospital. However, sometimes that just cannot be prevented. Okay. They have complications. Mm-hmm. The illness gets worse, or it may just be that the illness is playing out is, it's the way that the illness is going to get worse before it gets better. Mm-hmm. We don't turn patients away, and every time a patient comes in, a case manager goes right back to the drawing board to try to figure out how they can tweak the plan or make it better. We don't give up on patients. And as long as patients don't give up on themselves, we work with them.
Okay. All right. Thank you. And I see we have another caller on the line. Go ahead, caller.
Yes. She actually almost answered my question.
That's the same caller.
I'm talking about drug abusers. How many times does a drug abuser get to go to the young lady's place before you have to give up on her or him and take another patient in to give them a try?
Okay.
Now you got my question.
So if, I don't work in the area of where the drug abusers, we don't have a program that has substance abuse inpatient. That is more of we have a mental health unit. A lot of times we do get the patients if they were admitted because they were medically unstable. Mm-hmm. And what they do is they stabilize them, and then they may transfer them to an inpatient facility that does substance abuse, or if it is something that is dual diagnosis that has mental health as a problem as well, they may be admitted to our inpatient mental health unit. But those patients, by the nature of their illness, they come back over and over and over again. A lot of times they'll even tell us that they don't want any help. We offer them the help. If they refuse to take it, the patient has the right to make a bad decision, or they have the right, as long as they are considered able to make decisions and functional, they have a right to make a bad decision. But we as a healthcare worker, we don't push them out. Now, there are some things that happen that they say they're stable and they can be discharged, and we discharge them because of that. But we don't say, well, you're getting discharged because we can't help you anymore. That's not the case, and that is for patients that have drug problems, or patients that are non-compliant, or that just don't feel like that they have to follow their diet. I mean, if it wasn't for the patients, we wouldn't have a job.
Let me ask you this in regards to mental health. How effective, and maybe you know this, maybe you don't, how effective is the outpatient program? Because if a person is coming in and getting, the treatment that they need, and then going back home, and then the recidivists take place and they're back in and out, would the outpatient center be effective for that person?
We do have great means of outpatient care. We even
on the
have,
mental health side.
On the mental health
Okay.
side, I do know for sure that they have an intensive outpatient setup where the patients are seen almost every day. If the patient does follow that and comes in, a lot of times they can get the great help that they need.
Right.
But it has to be a collaboration between the patient wanting to do it, doing their part, as well as the counselors effectively managing and dealing with the issues. A lot of things can be done on the outpatient level. They don't keep patients inpatient very long, because once the acute care phase is completed, hospitals want to discharge, and insurances also want the patient to be discharged and either go to an outpatient facility or follow up outpatient with their doctors.
Okay. Now, if they truly are psychotic, and then within that inpatient stay, the problem was not resolved, how does that work? Do they just say, well, you've exhausted your number of days and you have to go and stay out for X number of days and then come back in? How does that process work as it relates on the mental health side, if you know?
Well, if they're psychotic and they bring them into the ER, we do have doctors that can distinguish if they are having a psychotic break.
Gotcha.
They will try to stabilize them with medication, and they may even have to restrain them.
Okay.
Once the patient has been stabilized and restrained, we actually have crisis intervention and psychiatrists that intervene, and they make the decision whether the patient needs to be admitted. And sometimes they even make a decision whether the patient needs to be admitted against their, they might want to go home, but there are ways that they can certify them so that they can be admitted under certification.
Okay.
And I worked in psych, but it was an adolescent psych, so
Okay.
this is my definition. I know those things just because I had a little bit of experience with psychiatric care.
Right. Let's go back to the acute side. Once the client is discharged, what options do they have going home? I know and I hear a lot of nurses now are going into home health. So how does that work with case management, and how does that process work?
So home health is actually one of the areas that we actually set up for patients that are nearing what we call stability and readiness to transfer to a different level of care.
Okay.
That level of care may be home with home health services, or it may be that they may need rehab or a skilled nursing facility. we try to give the patient the best option based on like their therapy evaluation or the occupational therapy evaluation. Sometimes the patient disagrees with what is recommended for them. A lot of patients just actually are afraid of going to a skilled nursing facility, or they may have heard others that had bad care, or they may have had a time when they went to one and had bad care. So if they opt out of not going to the skilled nursing facility, a lot of times we can set up home health for them and or outpatient physical therapy. Those may not be what the main recommendation were, but we have to listen to what the patient is asking for. And a lot of times, the patient may go home and they may realize that they made a bad decision. They can be admitted to a skilled nursing facility if they had a qualifying stay within that month. They could still be admitted to a skilled nursing facility. We do try to listen to the patients and the patient's families, because when a patient goes home, the only people that they have to depend on are their families and the home health nurse or the homemaker if they have one.
Okay. So it kind of sounds like the utilization or case management department is the advocate.
Yes,
between
definitely.
The patient and whatever their disposition is. Is that what it kind of how it goes?
That's correct. We are in the middle of the patient getting what they need, as well as hospital resources being used wisely. We are right in the middle of that, and we give advice to doctors based on what the recommendations are, or sometimes if we're trying to figure out what the plan is, we may ask for assistance from physical therapy to help us, occupational therapy. We may ask for spiritual care to intervene. We depend on an interdisciplinary team to help us make decisions. At Mercy Hospital, we have interdisciplinary rounds every day. Around the same time, 10:30, they know we're going to have rounds. And that includes physical therapy, the pharmacist, the doctors, the nurses, the charge nurse. We sometimes have nutrition there, social workers. And at that time, when we go over the patients, it's not very long and drawn out. It's the quick and dirty, but we want to know, what do we need to do? What is exactly necessary to get this patient to the next level where they can be ready for discharge? What are they going to need? And each person has their part to play in getting that patient to where they need to be.
Okay, scenario, Ms. Walton. If a client goes home and they don't need all of those disciplinary persons to come in, home health is in the house. How do you set that up before they leave, or is it determined once they go home? Because with them making their rounds, you may not need the spiritual person to go and be a part of home health. You may not need physical therapy. You just might need skilled nursing or some teaching or that type of thing. So how does that?
Yes, we definitely set that up prior to the patient leaving. If they have a private insurance, they may have to choose from a list of in-network providers. That means providers that they will get more bang for their buck from, because their insurance has said, we know that this is one of our providers in your network, and we'll pay, at the most highest level for this provider. But even then, they have more than one choice. They have several choices that they can choose. And a lot of times they say, well, I don't know anything about this, you choose. Well, we try to make sure that the referral that we make will be in network for that patient, and that patient can have home health services. Home health services are skilled services. It's not just where they come and sit and talk. They either need physical therapy, wound care, follow up on medication, teaching for the family. Those things are considered skilled and can be done by a registered nurse or physical therapist. It is not just the homemaker part of it, although we do offer homemaker services. We make a referral for that, but we can't guarantee that because it's under the jurisdiction of the Department of Aging or the Department of Rehabilitation.
Okay, and I know where our time is it's limited here, Ms. Walton. Just real quickly, I want you to talk about Medicaid versus Medicare as it relates to patients going home. If they're a certain age, do they qualify, or do they have to pay for the services at home, or how does that work?
Well, Medicare is skilled nursing is a covered benefit for a patient that has a skilled need.
Okay.
Medicaid is an insurance also, and I am just going to be honest, it's a little harder sometimes to get skilled nursing facilities to go into homes that have Medicaid only, because the state of affairs in Illinois is that the state is not paying and they don't get paid.
Right.
But we try very hard to even give Medicaid patients home health when they need it.
Okay, very good. Thank you so much, Ms. Walton. I just
Thank
would like to
you.
thank you. And I want to again emphasize that we have Ms. Bernetta Pearson here with us today, and we're just so happy to see her. And she's looking real good. Ms. Walton, just tell us about your organization, Black Nurses. When I talk to a lot of nurses, they said, never heard of it, and who are they and what they do. And can you just tell us real quickly who are Black nurses and what do you do?
Well, the Chicago chapter, National Black Nurses Association, we are a nursing organization for nurses, student nurses, licensed practical nurses, registered nurses.
Okay.
We meet on the second Saturday of the month. Presently, our meeting place is Lutheran Theological Institute, 1100 East 55th Street.
Okay.
We have meetings where we are involved in mentoring. We give scholarships. The number to call for further information is 773-779-7222. We do have a correspondent secretary that answers and fields those calls.
Give that number again, Ms. Walton.
It is 773-779-7222.
Okay.
We also have a website, which is Chicago Chapter National Black Nurses Organization website. And we're having an event, the main event that we usually have for our fundraising for the year. It is going to be a luncheon this year. It's $50. The date is November 4th. And the place that we're having it is Harborside golf course. And it's a very well kept secret, but it's a beautiful place. It's from 12 noon to 4 p.m. So for those that don't want to stay out too late and have to go to church on Sunday, we are having it in the afternoon. And we would like for as many as possible to come to help us. We will give scholarships and operational costs, all based on this fundraiser. It's one of our main fundraisers for the year.
Okay, very good. And we certainly want to thank you, Ms. Walton, for being
Thank
a part
you.
of this interview today. And as we said, you know, health is wealth. And if you don't have your health, you don't have nothing. So we just thank you so much for joining us today. Thank the caller for calling in, and hopefully she was able to clarify a little bit of what you were asking. And we'll see you next month, okay? Thank you. Have a good evening. Bye-bye.
Bye.